This video provides you with an overview of the joints of the upper limb. Before we look at these specific joints of the upper limb, I first want to expose you to the concept of a joint and the different types of joints that we'll encounter along the way. A joint is defined as a site where two skeletal elements meet, a site where two or more bones articulate with one another. In addition to discussing joints, we'll also cover a number of different ligaments in this video. So what is a ligament? Ligaments that are associated with joints are bands of dense fibrous connective tissue that connect two bones and provide stability to the joint. In general, joints are classified into two major types, non-synovial joints and synovial joints. Non-synovial joints are sometimes described as synarthroses joints, which means to bind together. In other words, these joints permit either no movement or very little movement between skeletal elements. Non-synovial joints are further divided into fibrous and cartilaginous joints. These sutures in the skull are an example of a fibrous joint that permits no movement between the bones of the skull once the sutures fuse with one another. On the other hand, the dense fibrous connective tissue of the interosseous membrane between the radius and the ulna does permit some movement. Otherwise, it would be nearly impossible to supinate and pronate the forearm. Non-synovial cartilaginous joints come in two flavors. The first are synchondroses joints, which are composed of hyaline cartilage and are found in the epiphyseal growth plates of the bones. Another example of a synchondrosis joint would be the sternocostal joints along the anterior thoracic wall. The second type of non-synovial cartilaginous joint is a symphysis joint, in which fibrocartilage fills the gap between two bones. Examples include intervertebral discs and the pubic symphysis. Symphysis joints are considered to be amphiarthrosis joints, meaning they are slightly mobile. The take-home message here regarding non-synovial joints is that they either allow no movement or very restrictive movements. What sets synovial joints apart from non-synovial joints is that they, number one, are often highly mobile, and number two, they contain synovial fluid, which is a lubricant that decreases friction between articulating surfaces, thereby allowing for a smooth gliding between bones. Synovial joints come in a variety of flavors. In this video, we'll be most concerned with the ball and socket joint and with the hinge joint of the elbow. Here's an example of the ball and socket joint of the shoulder, which we'll spend a lot of time with, and here's the hinge joint of the elbow. Because synovial joints are the most common type of joint, let's take a moment to look intently at what a typical synovial joint consists of. At the ends of the articulating bones is articular cartilage, made up of hyaline cartilage. These articular cartilages act as thin shock absorbers, distributing the mechanical load to the subchondral bone. Because articular cartilage is avascular, it receives nourishment from the synovial fluid that fills the synovial joint cavity. Here's the synovial cavity, filled with synovial fluid. Keeping the synovial fluid in place and from leaking out of the joint cavity is the thin synovial membrane, which lines the joint space. This synovial membrane is responsible for secreting the synovial fluid. The synovial joint capsule lies just superficial to the synovial membrane, and its fibers blend with the periosteum of the bone, as you can see here. However, neither the synovial membrane nor the fibrous joint capsule are strong enough to maintain the integrity of the joint. Therefore, capsular ligaments, which are often adherent with the fibrous joint capsule, function to stabilize the joint. Extracapsular ligaments are those found outside of the joint capsule, and intracapsular ligaments are those located within the joint capsule, such as the ACL in the knee, for example. There are a number of factors which contribute to joint stability. These factors include the shape of the articular surfaces, the strength of the joint capsule and the extracapsular ligaments, and the tone of the muscles surrounding the joint itself. If the articular cartilage, for example, wears thin, such as shown here, the underlying bone can become exposed, thereby causing pain, because unlike cartilage, bone is very well innervated. Now let's look at some specific joints, starting with the 4 joints related to the shoulder complex. The first relevant joint is the sternoclavicular joint, which is the only articulating connection between the upper extremity and the axial skeleton. At the sternoclavicular joint, the sternum and the clavicle are separated by an articular disc of fibrocartilage, shown here. The ligaments of this joint are so strong that upon forceful downward traction of the lateral clavicle, the clavicle usually fails and fractures before the joint actually dislocates. The 2 main ligaments responsible for stabilizing this joint are the sternoclavicular ligament, spanning from the manubrium of the sternum to the clavicle, and the costoclavicular ligament, spanning from the first costal cartilage of rib 1 to the undersurface of the clavicle. The second joint of the shoulder complex is the scapulothoracic joint. While the movements of the scapula along the posterior thoracic wall function like a joint, it is not a true anatomical joint because it does not involve the classic articulation between 2 bones. Recall there are actually muscles between the undersurface of the scapula and the thoracic wall. As such, the scapulothoracic joint is actually considered to be a functional or physiologic joint. The last 2 joints are the AC joint, which is the acromioclavicular joint, and the GH joint, which is the abbreviation for the glenohumeral joint. Of the joints of the shoulder complex, these 2 joints are most important clinically. As such, that's where we'll focus most of our attention. Not only is the scapula suspended by muscles, but it is also secured to the clavicle through a series of fibrous ligaments. The coracoclavicular ligament is very strong and affixes the coracoid process shown here of the scapula to the clavicle lying just above. Technically, this ligament is divided into 2 ligaments, but don't worry about that. Do recognize, however, that the coracoclavicular ligament does provide some integrity and stability to the AC joint, the acromioclavicular joint. Comparatively speaking, the acromioclavicular ligament shown here is much weaker and much smaller than the coracoclavicular ligaments. The acromioclavicular ligament secures the acromion of the scapula to the clavicle, and it helps to reinforce the AC joint capsule. Thirdly, the very broad coracoacromial ligament bridges the distance between the coracoid process and the acromion of the scapula. Sometimes you may hear this referred to as the coracoacromial arch. Specifically, that arch includes the acromion, the coracoacromial ligament, as well as the coracoid process. Functionally, the coracoacromial ligament helps to resist upward displacement of the humerus from the glenoid cavity. If a patient happens to suffer from chronic repetitive upward displacement of the humerus, it may lead to an impingement injury of the supraspinatus tendon and could lead subsequently to shoulder pain. In this instance, I'd like to give the example patient of a gymnast who is on the pommel horse doing their routine. A gymnast on the pommel horse is using nothing but their upper limbs to support the entire weight of their body, and so you can imagine they might have some upward displacement of the humerus. Let's suppose that a skateboarder was grinding down a handrail, fell off, and landed on an outstretched hand. From now on, we'll refer to that as a FOOSH injury, abbreviated FOOSH. This stands for a fall on outstretched hand. As you might imagine, the force of this fall can put excessive strain on the shoulder complex, so much so that the skateboarder could dislocate his AC joint, which is also referred to as shoulder separation. Dislocation of the acromioclavicular joint involves rupture of both the coracoclavicular ligaments, shown here, and the acromioclavicular ligament, shown here. When this occurs, the lateral part of the clavicle is pulled upward due to the tonic contraction of the trapezius muscle, and the rest of the shoulder complex drops due to the weight of the arm and due to the fact that it's no longer connected by the clavicle to the axial skeleton. If there is in fact a complete rupture of both ligaments, repair usually requires surgical restabilization. The hallmark sign of shoulder separation, aka AC joint dislocation, that is observed upon physical examination of a patient is a characteristic stair-step deformity. In other words, the upward displacement of the clavicle sits just above the level of the acromion. In the radiograph in the lower left of the screen, here's the clavicle labeled C, and here's the acromion labeled A. Notice the stair-step deformity. In the upper right of the screen is a normal radiograph of an AC joint. Notice the gap between the bones. This is normal, because don't forget there's articular cartilage lining the surfaces of these bones, and articular cartilage is not visualized on X-ray. And as a reminder, that articular cartilage is made up of hyaline cartilage. Also notice that ligaments cannot be visualized on X-ray either. The ligament in this case would be the AC ligament, which would span between the acromion and clavicle. You're already familiar with these movements, but let me remind you that full abduction of the arm requires upward rotation of the scapula, and secondly, circumduction involves all of the basic movements of the arm combined. And by way of general principles, understand that joint mobility comes at the cost of stability. The glenohumeral joint is a synovial ball and socket joint between the head of the humerus and the glenoid cavity of the scapula. Interestingly enough, the relationship between the head of the humerus and the glenoid cavity is much like that of a golf ball on a tee. That is, the size of the ball is much larger than the socket it's seated in. Because the glenoid cavity is very shallow, at its perimeter there is a rim of fibrocartilage called the glenoid labrum. This labrum slightly deepens the glenoid cavity for a better fit with the head of the humerus. On occasion, the glenoid labrum can tear, either from repetitive shoulder movements, such as overhead sports like throwing and swimming, or from traumatic injury. A torn glenoid labrum often presents with pain upon shoulder movements, and if severe enough, could limit shoulder mobility. On a T2 weighted image of an MRI of the shoulder joint, the synovial fluid within the joint capsule is bright white, and cartilaginous tissue appears dark gray. In this MRI, you can see a pool of synovial fluid shown here within what is called the axillary recess. You'll see how the axillary recess of the joint capsule is formed in just a moment. The MRI to the right demonstrates a slap tear in which the superior labrum has become torn both anterior and posterior to the biceps tendon, as demonstrated in the illustration above by the orange tear. An outpatient procedure in the form of arthroscopic surgery can be performed to repair a slap tear. Because the glenohumeral joint is a synovial joint, it is surrounded by both a joint capsule as well as extracapsular ligaments. Anteriorly, the joint is reinforced by 3 glenohumeral ligaments, which are fibrous bands that blend with the joint capsule. Superiorly, the joint is reinforced by the coracohumeral ligament, which spans from the base of the coracoid process over to the humerus. In addition to these ligaments, don't forget that the tendons of the rotator cuff muscles further help to reinforce this joint. In the image to the right, you see a joint space lined by a synovial membrane. Notice how the synovial membrane extends into the intertubercular sulcus to form a sheath around the tendon of the long head of the biceps muscle. This sheath allows for frictionless movements between the tendon and the humerus. Also notice the transverse humeral ligament that bridges between the greater tuberosity of the humerus and the lesser tuberosity. This ligament prevents the tendon from slipping out of the sulcus during movements of the glenohumeral joint, especially those movements overhead. I'll also point out the axillary recess. This is a pouch-like area at the inferior boundary of the joint capsule where the excess slack of the joint capsule gathers when the arm is adducted. When the arm is abducted, the axillary recess is pulled taut. As I mentioned earlier, the mobility of the glenohumeral joint comes at the cost of stability. The glenohumeral joint is the most commonly dislocated large joint in the body. The most common type of shoulder dislocation is an anterior dislocation, also known as a subcoracoid dislocation. In this form of humeral dislocation, the head of the humerus slips out of the glenoid fossa and is pulled underneath of the coracoid process due to muscular traction from the rotator cuff muscles. It is called an anterior dislocation because the head of the humerus comes to lie anterior to the scapula. It makes sense that the humeral head slips out inferiorly because there are no muscles or ligaments reinforcing the inferior portion of the joint. Recall that the glenohumeral ligaments and the rotator cuff muscles reinforce the anterior, posterior, and superior aspects of the joint. In the upper right image, this patient suffers from a subcoracoid dislocation. Notice how his right arm is fixed at his side with slight lateral rotation. This tells us that it's an anterior dislocation because the head of the humerus is now facing more anteriorly than it once was when seated in the glenoid fossa. Also notice how the right shoulder has lost its roundness compared to the roundness of the left shoulder. This also suggests the humeral head has slipped inferiorly underneath the coracoid process. In the lower right image, the dislocation has been reduced, and notice how the roundness of his right shoulder has been restored. And I'm sure this patient is in much less pain at this point. The elbow joint is a hinge joint with three articulating bones: the humerus, the radius, and the ulna. Like a typical synovial joint, the elbow joint is encapsulated by a fibrous capsule. The two ligaments that reinforce this joint are the radial collateral ligament on the lateral aspect of the joint and the ulnar collateral ligament on the medial aspect. The articulation between the humerus and the ulna occurs between the spool-shaped trochlea, shown here, and the trochlear notch of the ulna. More specifically, the trochlear notch is formed by the olecranon, which is not visible in this image, and the anterior projecting coronoid process. The humeral radial joint is formed by the articulation of the capitulum of the humerus, shown here, with the concave surface of the radial head. Both the humeral ulnar and humeral radial joints permit flexion and extension of the forearm. During full flexion of the forearm, the head of the radius and the coronoid process are received by the radial and coronoid fossae, which are located just proximal to the capitulum and the trochlea respectively. The proximal radio-ulnar joint, as shown here, is a pivot joint. The head of the radius is received by a shallow radial notch on the lateral aspect of the coronoid process of the ulna. The proximal radio-ulnar joint is stabilized by the annular ligament, which helps to keep the head of the radius seated against the ulna. Because this joint is a pivot joint, it allows for supination and pronation of the forearm. As an aside, Tommy John surgery, which is common among baseball pitchers, is a reconstruction of the ulnar collateral ligament. During this procedure, a surgical graft is used to replace the ligament. The graft usually comes from the palmaris longus tendon. As you might imagine, overuse and repetitive stress, such as throwing a baseball, can damage this ligament, thereby leading to instability of the elbow joint. The olecranon, shown here along the posterior aspect of the elbow, acts as a short lever for extension of the elbow joint by the triceps brachii muscle. The olecranon fossa of the humerus, shown here, accommodates the olecranon during full extension of the forearm. The shaft of the distal humerus flares out as the medial and lateral supracondylar ridges, and these ridges end at the medial and lateral epicondyles of the humerus. What you learn in regards to osteology is easily transferable to radiology, so let's review some of these structures. Here's the capitulum of the humerus, just lateral to the trochlea of the humerus. Here's the head of the radius articulating with the capitulum and the coronoid process articulating with the trochlea. And here you see the shallow olecranon fossa, which is on the posterior aspect of the humerus. And here's a really nice example of the trochlear notch. In a posterior dislocation of the elbow, the radius and ulna are displaced behind the distal humerus, as shown here. And when this happens, the ulnar collateral ligament is often torn in conjunction with the dislocation. It is also possible for the head of the radius and the coronoid process to become fractured during a posterior dislocation. As you will learn later, the ulnar nerve is at risk for injury in this type of dislocation because of its course just posterior to the medial epicondyle in the ulnar groove. To reduce this dislocation requires that the physician place downward traction on the forearm bones while also pulling those bones back into alignment. When my daughter was really young, around the age of 1, I picked her up by her hands and we spun around and around in circles until her feet came off the ground. Well, as soon as I sat her down, she started bawling hysterically. Not only that, she was pointing straight to her elbow. Luckily, I knew exactly what had happened. I had partially dislocated the head of her radius, and so her radius was pinching on her annular ligament. This is known as nursemaid's elbow. Without hesitation, I flexed and then supinated her forearm, and almost instantly her outcry changed to a little whimper. Luckily, the subluxation had been reduced. Needless to say, after that, the spinning game was temporarily banned. At the wrist joint, which is known as the radiocarpal joint, the radius articulates directly with the first row of carpal bones, as shown here. Notice how the ulna does not participate in the wrist joint. There is a gap between the ulna and the carpal bones. In this gap, there is an articular disc that separates the head of the ulna from the first row of carpal bones. This articular disc is sometimes called the triangular fibrocartilage. The articular disc and the radial ulnar ligaments surround it and are responsible for keeping the ulnar head in contact with the radius. The joint encircled here is therefore referred to as the distal radio-ulnar joint. Key bony landmarks of this region include the styloid process of the radius, shown here, and the styloid process of the ulna, shown here. And by the way, the styloid process of the ulna is that bump that you see near your wrist on the extensor side of your forearm. The wrist itself is capable of a number of movements. Flexion of the wrist indicates that the angle of the wrist has decreased between the anterior forearm and the palm of the hand. Extension of the wrist means that the palm of the hand and the anterior forearm have increased in their angle. During radial deviation, the hand is moving toward the side of the radius, and likewise during ulnar deviation, the hand moves toward the side of the ulnar bone. And lastly, the forearm can be either supinated or pronated. If you're holding a bowl of soup in your hands, then your forearms are supinated. Pronation is just the opposite, when your palms are facing down toward the ground. The two muscles responsible for pronation of the forearm would be the pronator quadratus as well as the pronator teres muscle. And the two muscles responsible for supination of the forearm would be the supinator muscle along with the biceps brachii muscle. Because the distal radius articulates with the carpal bones at the wrist joint, the distal radius is at risk for fracture if there is a sudden transfer of weight to the upper limb. This type of fracture from a fall on an outstretched hand is referred to as a Colles fracture. Colles fractures are very common in the elderly, second only to hip fractures. They are also common in individuals with osteoporosis. A Colles fracture is a transverse fracture of the distal radius. Colles fractures present with a characteristic dinner fork deformity because the wrist and subsequent angle of the forearm resemble the curve of a dinner fork. This is because the distal radius has been displaced dorsally from falling on an extended wrist. In a Smith's fracture, just the opposite has occurred. The distal radius is displaced anteriorly in a Smith's fracture from falling on a flexed wrist instead of falling on an extended wrist in the case of a Colles fracture. The wrist is also called the carpus, and it is composed of 8 carpal bones arranged in 2 rows. Functionally, the carpal bones give flexibility to the wrist, and as you'll eventually learn, they create a carpal tunnel. Now, there are many mnemonics for carpal bones, and of course, the dirtier the mnemonic, the easier it is to remember. For the sake of this video, I'll keep it clean. The mnemonic shown here is Sally left the party to take Kathy home. Each letter in this mnemonic represents a letter for each of the 8 carpal bones. The scaphoid is the largest of the 8 carpal bones and happens to be the one most commonly fractured. Just adjacent to the scaphoid is the lunate bone, and adjacent to that bone is the triquetrum. The pisiform bone is a small pea-shaped sesamoid bone that lies on the palmar surface of the triquetrum, shown here. By the way, the word pisum in the Latin means pea. This bone can be palpated on the proximal medial palm at the base of the hypothenar eminence, shown here. And the thumb swings on the trapezium, shown here. Think of an acrobat swinging on a trapeze. The hamate has a very characteristic hook called the hook of the hamate bone. This hook forms part of the border of the carpal tunnel. And interposed between the hamate bone and the trapezium are both the capitate bone as well as the trapezoid, which is literally shaped like a trapezoid. The skeleton of the palm of the hand is formed by 5 metacarpal bones that each have a base, a shaft, and a head. And each digit has 3 phalanges, except for the thumb, which only has 2. In other words, there is a proximal, middle, and distal phalanx that forms each digit, except for the thumb, which only has a distal and proximal phalanx. And between all these bones of the hand and wrist are a series of joints. The carpometacarpal joints are situated where the base of the metacarpals articulate with the carpal bones. The very first carpometacarpal joint shown here is a saddle joint, which allows for maximized movements of the thumb. The metacarpal phalangeal joints, abbreviated MCP joints, are formed by the heads of the metacarpals articulating with the proximal phalanges. These joints represent what you think of as your knuckles on your hand. And then each digit, except for the thumb, has 2 interphalangeal joints. There's a pip joint, which is a proximal interphalangeal joint, and there are also dip joints, distal interphalangeal joints. The thumb, however, only has a single interphalangeal joint. This concludes the video on the joints of the upper limb. Until next time, happy studying!